Happy Teach Me Tuesday. My name is Lisa. I am a NICU nurse educator and an experienced NICU nurse here with another topic for all of the NICU nurses out there, whether you are new and a novice or experienced and looking for ways to grow in your knowledge. Today, March 25th, is Cerebral Palsy Awareness Day, CP Awareness Day, Cerebral Palsy Awareness Day. If you've been following me on Instagram over the weekend, we were talking about how to spell preemie and how to pronounce it. And I've learned that maybe I'm not the greatest pronouncer at things. So especially since I got this lovely retainer, I'm so sorry if that is bothering you. But let's dive into today's content. So we don't always think about cerebral palsy as NICU nurses, right? Because it might not be something that we're necessarily seeing during the baby's stay. And that's going to be especially true if you work in a level 2 or a level 3A that maybe ships babies after they get to 44 weeks. You're not doing trachs or buttons, any of those big surgeries. Or you could be someone that keeps babies until they're about a year old and maybe you're starting to see signs of it. But really, we think about this a lot with outpatient. But I think it's good for us to all have an awareness of what it is and what we can be doing in the NICU to help prevent some of it, what we could be watching for as signs of it, and how we could maybe know how to set parents up for success and what this might look like for their baby long term, because this affects 1 in 345 children in the United States. It's caused by damage to the brain either before, during, or kind of after birth. That can be in the moments immediately after birth or during a NICU stay, which we'll talk about kind of the differences. Often we see challenges with movement, posture, muscle tone, and these babies often have a long time in therapy throughout their life. And it is a wide range, which I think is sometimes what makes it so tricky when we're telling parents, hey, these are possible long-term outcomes of a NICU stay, is we don't always know what it's going to look like because it can be so different from baby to baby. But advances in NICU care, neuroprotection strategies, and these therapies that we've learned, and we learned so much about early intervention, have really improved outcomes for these infants over time. So 85 to 90% of these cases are happening kind of right before or during birth. 8 to 15% of premature babies born less than 28 weeks will develop CP, which is very high when you compare that to term babies, which is in a less than 1% volume. Multiple gestations is going to increase your risk. And then those birth complications account for about 10% of cases. So think about those HIE kids, placental abruption, all of that. And in March, it's Cerebral Palsy Awareness Month. You're going to see me wearing green today on Tuesday. It's just, this is what we're doing to celebrate and honor these babies. So what are the risk factors? So prenatally, you can think about infections, placental insufficiency. To know me is to know my love of the placenta and how it really, really affects the baby in utero and in their life after. And with placental insufficiency, you have to think about if the placenta cannot exchange the gases appropriately, there's going to be an oxygen deprivation in the baby, right? And not only have we talked about this as a risk for neck and other issues the baby may have in the NICU, but this can cause long-term outcomes with neural development. So something to think about. And then there are some genetic things that play into CP. We're learning more about that every day as we learn more and more about our genetic coding. And then we talk about perinatal, so what's going on during birth. So birth asphyxiation, lack of oxygen during birth, that can be cord. We talked about all these things. We're going to talk about HIE a lot in April, so come back for that. Cord compression, cord constriction, nuchal cord. It can come from placental abruption, all of that. Then we have intracranial hemorrhage, so those brain bleeds that are either happening right before birth, during birth, or after, and especially in those extremely premature babies. And then postnatal, neonatal sepsis and meningitis. We don't always think about how this can affect the babies. About 2 years ago, there was twins in the NICU I was working in, and they're boy-girl twins, so they had different sacs, and one of them ended up with GBS meningitis and was severely compromised from that, both short-term and long-term. And the sister didn't have it because she was in a completely different sac. And so this idea of, at first he seemed to be doing well. They weren't too premature. I don't remember how young they were, maybe 30, 32 weeks. And then when the GBS came on, he is extremely sick, had long periods of oxygen deprivation, and he will have more long-term outcomes with his CP diagnosis. We've talked about jaundice with kernicterus, and then obviously there are babies that have other issues such as shaken baby syndrome or accidents. I have a acquaintance from college who, when her infant was very young, they were in a very traumatic car accident, and she has CP from that. So those are the wide range. So we've asked ourselves, is this genetic? Is it hereditary? And while there are some things that are inherited, that is not usually like our big risk factor. It's more of these things that are happening that cause the brain to develop abnormally. So again, we're back to that birth asphyxia, prematurity and low birth weight, causing a NICU stay, causing oxygen deprivation, maternal factors, and then the traumatic brain injuries. The brain injuries, let's talk about specifically the NICU. So what's happening with those preemies in the NICU? If you're following along on Instagram, see, I changed my ways. I spelled it with 2 E's, Preemie. So brain injuries in preemies, this is something that's happening in the NICU. IVH, PVL, HIE, fluctuating oxygen levels, and then obviously our prolonged mechanical ventilation all increase the risk for CP. IVH. We do our IVH bundles now. We know that the first 72 hours, maybe 96, is the most important. We know the things that reduce our risk of IVH. That's going to include gentle ventilation. It's going to include doing skin-to-skin care with the families. It's going to include watching major swings in your blood pressure, watching major changes with your flushes so we're not rushing that intracranial pressure. We don't talk enough about fluctuating oxygen levels and prolonged mechanical ventilation. In those periods of hypoxia that may not seem severe, what happens at birth, but these periods that are happening short term over and over again are what's increasing a premature baby's risk for CP. Again, with our infections and our inflammation, thinking about neck and what happens with neck and a baby having to go to surgery for neck, all of that is increasing their risk for CP. And then any of those prolonged hypoxia, needing resuscitation at birth, unstable blood pressure, the perfusion problems, we talked about the importance as a NICU nurse of checking your capillary refill, all of that is going to play into this. Which also factors into our term babies, right? This goes both ways. So our term babies, we think a lot about that perinatal stroke, those difficult deliveries, whether that's with a vacuum, forceps, shoulder dystocia. You hear about those home births that kind of go wrong and the baby comes in and they have had issues and now they're having those long-term outcomes. It's always so tricky to me. Someone asked me what's kind of the hard side of the NICU? And I think the hardest part for me to get used to that I was not prepared for going in is this idea of a term baby with a normal pregnancy, quote unquote, right? What's normal? And this idea of you have something happen during this term vaginal birth that you weren't anticipating. It has all these long-term outcomes. We're more prepared as NICU nurses, as NICU providers, as NICU parents when your baby's born early that they may have long-term outcomes that are not as great or harder for them to overcome. But we don't always anticipate that with term births, and that was hard for me when I first started to kind of wrap my head around. With HIE, we think about cord accidents, prolapse, nuchal cord, true knot, placental abruption, uterine rupture, all of those things that are going to increase the risk. We do cooling, obviously, to help minimize that risk. We cool in the first 6 hours for the reperfusion injury prevention, come back in April. And then with severe hyperbilirubinemia, that bilirubin will cross the blood-brain barrier, cause kernicterus, which causes brain damage. So with our preterm babies, we're thinking so much about IVH, PVL, oxygen deprivation. What does IVH and PVL cause in regards to ischemic injury, where we think mostly that HIE happens in term babies? You can have these ischemic encephalopathic episodes in preterm babies. And then in term babies, we're thinking more what happens during birth or immediately thereafter that could cause issues for the baby. So when you think about our types of CP, with spastic, that's our most common. We have those stiff, jerky movements. Dyskinetic is that uncontrolled, the twisting, the writhing of the baby. Ataxic is when you see the balance and the coordination. And mixed is the most common. We see spastic, but you're probably going to see something else mixed in there. I was doing a lot of reading. There are some great websites I'm going to be sharing on my Instagram stories today. So if you're not following me on Instagram, go back and check that out. Some great organizations out there that really have a lot of amazing information. And if you are with a family that maybe their baby was diagnosed with a grade 4 IVH, and we think this is maybe a likely outcome, that you could point them in that direction for them to get some support, which is going to come from therapy and management. We start physical therapy so early now, even in the NICU, as you know. Remember, I mentioned this before. Occupational therapy was not something that we saw in the NICU when I started. I'm an old baby nurse, right? I'm past my 21 years. So longer than some people have been alive that I work with, which still blows my mind. But we know now that we can start them early in the NICU, and then they're going to continue that forever. That early intervention is so key. So physical therapy is for strengthening mobility. Occupational therapy is for adaptive skills, fine motor training. Speech therapy, often we have feeding issues, communication issues. I have a friend whose child has cerebral palsy, and they have learned to communicate with an iPad or a computer screen, and it's amazing what we can do now as long as we can continue to support these therapies. And then obviously some medications, if they're using Botox, they're doing other surgical interventions for the spasticity of the muscles. In the NICU, we can set them up for developmental care strategies, right? What can we do for positioning? What are we doing for muscle tone? What are we doing for joint protection? How can we minimize what these long-term brain changes are going to look like by minimizing noise, stress, and excessive handling? What are we doing for them for screening? Are we getting them their movement assessments? Are we doing MRIs? What are the close follow-up with developmental specialists? How can the NICU team communicate with that outpatient team, whether it is an outpatient therapy team, the pediatrician, etc.? And how are we getting those parents involved early and often to be doing the skin to skin, to be there for massage therapy, to be there when the physical therapist is there, right? The parents are the primary caregivers. They need to be able to do all of this more than we do, to be honest, right? So some of our long-term outcomes, really with that motor impairment, we're going to have the spasticity, the dystonia, and the ataxia. I think we all kind of know what that looks like. I think it's easier for us to think of what it looks like instead of what we can be doing, right? So remember, all the things that we're doing in the NICU, whether that is your IVH bundles, whether that is close monitoring of your oxygen to make sure that the baby is not having hypoxic spells, whether it's really encouraging things to do for early extubation or gentle ventilation so that we don't have lung damage, so that the lungs can better absorb the oxygen and help the brain. We want to remember, we can't undo what's already been done, right? If there's something happens at delivery, what we have to do now is help minimize what the long-term outcomes are going to be and how can we set the baby up for success. So that's what we as NICU nurses should be doing, so that their cognitive and communication challenges will be minimized. And then we also have these associated conditions with seizures, vision and hearing, and obviously some feeding and swallowing issues. My hope for you is that you can take some of these long-term outcomes and think to yourself, what can I be doing on my side as the bedside NICU nurse to be preventing that? Developmental positioning, skin to skin, getting your baby out skin to skin is so important. Watching your oxygen, making sure that we're not tolerating these kind of lower numbers of 90, 91, so that we don't hear the high alarm volume. Watching our blood gases, intervening, or getting a provider to intervene so we can make changes to our gases so that we keep that ventilation in a healthy range and prevent some of these long-term outcomes. So what can we tell our parents, right? That it's a spectrum. There's no two cases that are going to be the same. I think that the support is so important. How can we get them connected with support in their community? Do we have a parent support group in our NICU or a parent council? Is there someone that's gone through this that can come back and help, tell parents, hey, this is what you may need to anticipate, knowing we don't always know. There are new and newer treatments coming out all the time to help kids with CP. And what does that look like for them, and how can we best help them throughout their course? I think really supporting them and letting them know they're not alone. This is one of those diagnoses that feels so big and it feels so long-term and isolating. So what can we do to best support them now and in the future? So I want to come back to this again, right? This is our recap slide, but in here it says again, early detection, neuroprotection strategies. What can we be doing as NICU nurses? If you have a key takeaway from today, I really want you to think about, let's talk about some of the term things. If your baby's coming in for cooling, making sure that we're getting them to their core temperature of 33.5 within 1 hour of initiating cooling. Making sure we're still doing developmental care practices while on the cooling blanket. Let's talk about bilirubin. If you're taking care of a baby with high bilirubin, making sure we're watching it closely, keeping them under the lights as much as we can, remembering where their body surface area is. That head is an important part of that, making sure that's under the lights so that we can prevent kernicterus. If you are attending deliveries, making sure your NRP skills are up and ready to go for resuscitation of that baby that's already compromised. How can we bring them back so that we can get that oxygen circulating back to the brain quickly and efficiently? Now let's talk about our NICU babies. How are we making sure that we have a golden hour admission with a 72 or 96-hour neuroprotective care bundle in the hours following, because that is our most fragile window. We can't undo something that happened in utero, right? So if mom had a hypertensive crisis and the baby's delivered at 24 weeks, we already know that the placenta was in trouble and we've already had some issues, right? So now it's our job to say, hey, we've already seen those issues, so I'm going to make sure that we keep our oxygen in a safe zone, our blood pressure in a safe zone, make sure that I am not lifting the feet over the head for diaper changes, making sure I'm doing slow progressive changes, position changes when we move the baby, getting the baby out skin to skin, minimizing painful procedures, advocating to keep a line in if it's drawing so that we don't have to poke the baby for labs. All of those things are going to contribute to the long-term outcomes. And once the baby has it, we just need to confirm with the families, right? We're going to start therapies early. We're going to get this, feeding therapy going, physical therapy going, massage therapy going, and then encouraging them, setting them up for early intervention strategies, and knowing that they can go on to live these very happy, fulfilling lives, and that the spectrum is so great, and that we are doing everything we can to support them. So thank you for joining me today for CP Awareness Day. I hope you learned something, and join me next week for our first week of April, where we are actually going to dive into some NRP strategies. Have a great week.